Well, good afternoon, everyone, and particularly good afternoon to you, Paul. Thank you and the Public Health Association of Australia for giving me the absolute honour of presenting the Eileen Plant oration, even in such less than ideal circumstances. I'm not sure who's got the upper hand here. I know you can't interrupt me, Paul, to tell me that I'm going overtime, but on the other hand, I guess you can simply pull the plug. Never really made my mind up about video presentations. Their visual quality can be variable. They are second best to a live performer. But if in fact you're being addressed by a leading world figure, then these distractions seem worth it. Sadly, you're missing out on the key benefit here. As far as the speaker goes, you've got no way of gauging audience reaction. Who's nodding off, who's leaving, who gets whatever you call jokes. So I've hired an audience, and today I'm speaking to Jenny Furman, and she's been paid to stay and to stay awake. She's even got scorecards to get my attention as I go along. I'm going to intersperse this presentation with some slides, at which time I'll be heard and not seen. Will benefit to you all, I think. I hope this presentation isn't too distracting or disjointed to you, but I do seem to have some expert technicians at this end in Peter and Hector. Pity they didn't bring along a teleprompt, that would have made it even easier. I was fortunate enough to meet Eileen when I was the South Australian Chief Medical Officer and attended the Australian Health Protection Principal Committee meetings, of course with its different acronym in those days, when it was chaired by Mary Manane. A lot of focus at that time was on H5N1 avian influenza and its potential to develop into a pandemic. Here, Eileen provided her wise input. She was knowledgeable and unassuming, ever polite and friendly, even to rank novices like me. I realise now how little I knew of her, having read some of her obituaries. Jeremy McAnulty, Louisa Jorm and Raina McIntyre wrote in the New South Wales Public Health Bulletin, John Matthews in the Medical Journal of Australia, and Melissa Sweet in the British Medical Journal. There are others. I've had the opportunity to meet and talk with the Director General of the World Health Organization, Dr. Margaret Chan, on a number of occasions, most recently last week at the World Health Assembly in Geneva. I've been struck by her clarity of thought and expression. ProMed records this message from Margaret the day after Aileen's death in May 2007. And to quote, WHO and the public health community mourn the death of Dr. Eileen Plant. Today, I would like to express my most sincere condolences to the family, friends and colleagues of Dr. Eileen Plant. Dr. Plant of Australia was a renowned medical epidemiologist, an outstanding global public health leader, and a long-time friend to the public health community. She was a path-blazing, respected lecturer, teacher and writer. Many at the World Health Organization considered her a mentor. She worked extensively with the World Health Organization. Dr. Plant made enormous contributions to the health and welfare of people in her country and to the world. In the very early weeks of the SARS outbreak in Vietnam, she was instrumental in analysing the threat. She was a core part of the team which designed the influenza pandemic containment plan. And just this week in Indonesia, she helped to bring consensus on the challenging issues surrounding avian influenza virus sharing and ensuring access to influenza vaccine for developing countries. She never hesitated to travel to places where she was needed, and we needed her many, many times in extremely difficult situations. She brought a deep sense of duty, commitment, vast experience, ethics, courage and professionalism to her work. Those who knew her described her as the best, the beating heart, and a true servant of public health. We and many others will miss her personally and professionally very much. End of quote. I note that Eileen served as a long-standing member of CDNA and that she participated in the 2007 Communicable Disease Control Conference in Canberra. Now, if only this conference had been held in Canberra, but it had its turn recently, as I recall it. It does great credit to the Public Health Association of Australia and the conference organisers that they honour Aileen with this oration each year. What Aileen would have made of me delivering this oration, with my background, goodness knows. I believe she'd have been too polite to say and would only have offered encouragement. What I thought I'd do is present this oration as if I was giving Aileen a report on what's been happening in recent times, particularly in the area of emerging infectious diseases. It would be fascinating to hear what she made of it all. It's not a bad time for me to reflect on those aspects of emerging infectious diseases in which I've participated, both here as Chief Medical Officer, a role which will be completed for me next year, but also some while I was Chief Exec of the Australian Commission on Safety and Quality in Healthcare, where we paid great attention to healthcare-associated infections, to hand hygiene, to antimicrobial resistance, and to antimicrobial stewardship. Work that was captured in the end by the National Safety and Quality Health Service standards. And be in no doubt that while almost 70% of emerging infectious diseases are zoonoses, those that emerge in our hospitals, such as carbapenem-resistant Klebsiella, are of equal or greater concern, to my mind at least. One outcome with which I was pleased during my time at the Commission was that we were able to engage and to prompt into action RMAC chief execs and all health ministers in matters regarding infection, particularly in hospitals, using the hook of Staph aureus bacteremia. They understood enough from the media about golden staph and superbugs to know they should be worried about them and to be ready to adopt measures to combat them, which they have done, having been provided with clear, practical measures devised by the Commission, assisted by you in the audience today and your colleagues. And by the way, health ministers are the best and most assiduous components and exponents of hand hygiene, apart from infection control nurses, I've come across, so they've clearly been taught well. What I would be more likely to report to Aileen is my perspective on MERS and on Ebola. I'd also want to talk to her about developments in avian influenza, possibilities for pandemic influenza, the global pandemic influenza planning framework, and One Health, and so I shall in this oration. MERS is truly an emerging infectious disease, and Ebola, while not strictly so, has emerged in West Africa in horrible reality. It emerged too in the wider world, the developed world. It emerged as a threat which far, far outweighed its actual impact, no doubt to it having been fueled by Hollywood's efforts in the films Outbreak and Contagion. The social impact of the threat of emerging infectious diseases, how unlikely they may be to occur in reality, becomes very much the work of me and my Chief Health Officer colleagues. It also becomes your challenge as you endeavour to explain the epidemiology of these diseases to opinion leaders who may be only partially listening to infectious diseases experts. In the case of Ebola, our leaders were also listening to broader society, which no doubt had very strong views and a high level of concern about the threat posed by this disease. For reasons that remain a mystery to me, I was asked to chair the World Health Organization International Health Regulations Emergency Committee regarding MERS-CoV. Now, that's a disease that strikes puzzlement, not fear, in the public. Given Aileen's early and pivotal role with the World Health Organization as it faced up to SARS, given that SARS and MERS are both coronaviruses, I thought at some stage in this talk I'd display some rudimentary microbiological knowledge. She'd be fascinated by every aspect of this disease and would be keeping a close eye on it. She may well have held an intimate and detailed knowledge of the revised international health regulations, given that they were agreed in 2005. I would have to report to her that my IHR book was in pristine condition right up to the day before I chaired the first of what have been 8 meetings of the Emergency Committee. The role of an Emergency Committee was or is to advise the Director General of the World Health Organization whether it believes a public health emergency of international concern exists with respect to a particular disease. While there are guiding criteria, which I will list, the definition itself was always of sufficient clarity for me and the other 16 members appointed to the MERS Emergency Committee from around the world to guide our discussions. The committee, by the way, only ever met by teleconference, a challenge on its own, added to the challenge of coordinating a global teleconference with some unfriendly time zones, particularly for Australia at one end of the day and Chile at the other. The definition of a public health emergency of international concern is this, and I quote, "A public health emergency of international concern means an extraordinary event," and that word is important, "which is determined, 1, to constitute a public health risk to other states through the international spread of disease, and 2, to potentially require a coordinated international response." End of quote. The Emergency Committee has been unanimous on each occasion it has convened that these elements have not been met in respect to MERS. At least once that conclusion was not reached without considerable discussion. To assist in reaching a conclusion as to whether the event constitutes a public health risk, there are 11 questions listed in the appendices to the International Health Regulations, provided as a guide grouped under 4 criteria. The 4 criteria are: 1, is the public health impact of the event serious? 2, is the event unusual or unexpected? 3, is there a significant risk of international spread? And 4, is there a significant risk of international travel or trade restrictions? The guidance is that if 2 of the 4 criteria are met, a public health emergency of international concern should seriously be considered. Now, the 11 questions are: under criterion 1, now I realise this is hard to read, which is why you've got me here to just go to the key points. Is the public health impact of the event serious? So the questions under here is the number of cases and or number of deaths for this type of event large for the given place, time or population? 2, does the event have the potential to have a high public health impact? 3, is external help needed to detect, investigate, respond and control the current event or prevent new cases? Slides get easier now. Under criterion 2, is the event unusual or unexpected? There are 2 questions. 1, is the event unusual? And 2, is the event unexpected from a public health perspective? Those questions don't add much to the heading, do they? Under criterion 3, regarding the risk of international spread, there are also 2 questions. Is there evidence of an epidemiological link to similar events in other states? And is there any factor that should alert us to the potential for cross-border movement of the agent, vehicle or host? Under the final criterion, is there a significant risk of international travel or trade restrictions? There are 4 questions. Have similar events in the past resulted in international restriction on trade and or travel? Is the source suspected or known to be a food product, water or other good that might be contaminated, that has been exported or imported to or from other states? 3, has the event occurred in association with an international gathering or in an area of intense international tourism? And 4, has the event caused requests for more information by foreign officials or international media? Appropriately, advisors were added to the MERS Emergency Committee, and they had expertise in travel matters, in zoonoses, and in communication matters. The MERS Emergency Committee first met in July 2013 and last met on 4th of February this year. The key points that come from the committee are posted on the WHO website and are amplified on the Department of Health website. Some points have become rather repetitive because some of them have still not yet been resolved. On 5th of February, it was noted that all cases have had a history of residence in or travel to the Middle East. Then it was more than 85% from Saudi Arabia. That percentage has increased since that time. Or of contact with travellers returning from these areas. In February, 23 countries had at least one case. Make that now 24, with 5 cases reported in the last week from South Korea, originating with a traveller from Bahrain. I think that situation in South Korea makes it the largest cluster outside the Middle East. At a February meeting, there had been 977 laboratory confirmed cases with a 37% case fatality rate. Interestingly, a person who's been closely involved with MERS in the Middle East told me recently that there's been some active testing of asymptomatic people which has revealed a higher level of infection and therefore a lower case fatality rate than previously thought. That person, it must be said, has throughout minimised the impact and the threat of MERS. Other points that have been made include there have been no cases related to the Hajj in 2013 and 2014, which is quite remarkable. The need for universal application of just standard infection control precautions. This point has been made again and again as transmission in healthcare settings in the Middle East continue. The importance of infection prevention and control is repeatedly emphasised as our best weapon against emerging infectious diseases, yet we, and particularly doctors, are not so good at it. Camels are suspected to be the primary source of MERS infections for humans, but the exact routes of direct or indirect exposure are not fully understood, and further studies, particularly case control studies, are needed. We've been told repeatedly that the results of such studies are imminent. The World Health Organization continues to advise that people should avoid drinking raw camel milk or urine, or eating meat that has not been properly cooked. Now let this be a lifelong lesson for you all, even if our camels here have shown no evidence of infection with MERS. And the final point, there is no evidence of ongoing community transmission. I'm sure we'll be keeping an eye on the situation in South Korea. The Emergency Committee is on hold at present, but can be recalled at any time circumstances warrant it, and the World Health Organization is keeping a close eye on MERS. I remain quite concerned about its potential for more extensive and widespread harm, particularly if the capacity of the virus for ongoing transmission was to develop. What, I wonder, would Aileen have made of MERS, but what would she have made of the Ebola outbreak in West Africa, now mercifully edging closer to being brought under control? I was also appointed to this emergency committee, and the Ebola was the subject of much discussion at last week's World Health Assembly. In a speech to the Assembly, Margaret Chan opened by stating, "The Ebola outbreak in West Africa shook the World Health Organization to its core." She went on to list a 5-point plan to address the shortcomings that have been identified. A number of members of the Emergency Committee regarding Ebola are also members of the MERS Emergency Committee. One is Professor Oyewale Tomori from Redeemers University, Redemption City, Nigeria. He's been a virologist for the World Health Organization African region. He was quoted in an article published online in the Canadian Medical Association Journal newsletter on 4th of May, just a few weeks ago. The title of the article, as you can see, is Ebola Crisis Revealed Major Fault Lines. The article asked the questions, Who should be involved in a large-scale response to a public health emergency, and how should it be implemented? This is where Professor Tamori spoke very clearly about local factors, which I believe have not been publicly canvassed to any great extent in the general critique in the management of Ebola. Ebola came to West Africa spreading and swimming in the ocean of national apathy, denial and unpreparedness, he said. The Ebola response should have made better use of local expertise and considered issues such as corruption, noting that these factors exacerbate fragile health systems. There are certain things we don't talk about publicly, and those are the ones that are causing our problems, he added. You all know enough about the pathogenesis of Ebola virus disease for me not to go there in this oration. But I found myself talking about just that on numerous occasions to concerned people, to media, and to our most senior parliamentarians, where I was advocating for public health measures that were recommended by the Australian Health Protection Principal Committee and based in clinical knowledge and evidence. As a result, we didn't end up with thermal scanners at our airports, which was a good and appropriate outcome. We didn't end up with a national policy for compulsory 21-day quarantining of healthcare workers returning from the West African situation. We did end up with entry screening of travellers returning from West Africa, but we had some good company there, especially in the United Kingdom, Canada and the US. We did have many consistencies in the public health approaches in our states and territories in whom the responsibilities for public health measures lie. We weren't entirely consistent in all aspects, as the varying policies on the handling of healthcare workers after their return from Ebola-affected countries demonstrated. But neither were our main non-government organisations, Red Cross and MSF, consistent in this matter. Red Cross required 3 weeks home quarantine for their returnees, and MSF did not, but advised their members to comply with relevant state and territory authorities. Now this year I've undertaken for me an unusually high amount of international travel, as my fellow Chief Health Officers who stand in as acting chairs of the Health Protection Committee would attest. The number of Ebola forms that I've filled in is quite remarkable, and their reception when I come through the border is also quite remarkable. But what I do enjoy is reading those newspapers I can read, that is, those in English, when I'm overseas, where I invariably find well-considered, thought-provoking articles on matters relating to public health. So it was in March, where I picked up a copy of the International New York Times on Wednesday the 18th, when I was returning from the first World Health Organization Ministerial Global Action meeting on dementia. Bill Gates wrote the opinion piece you see on your slide now, How to Fight the Next Epidemic. And when Bill Gates provides an opinion, many people pay attention. I thought he made much sense, which of course will give him great relief, as I know he would have been sweating on my opinion. Whatever else comes out of the multiple reviews of the World Health Organization's actions on Ebola, the reflections on lessons learned by the whole world community will be just as helpful. Thus he wrote, much of the public discussion about the world's response to Ebola has focused on whether the World Health Organization, the Centers for Disease Control and Prevention and other groups could have responded more effectively. These are worthwhile questions, but they miss the larger point. The problem isn't so much that the system didn't work well enough. The problem is that we hardly have a system at all. To begin with, most poor countries, where a natural epidemic is most likely to start, have no systematic disease surveillance in place. Even once the Ebola crisis was recognised last year, there were no resources to effectively map where cases occur or to use people's travel patterns to predict where the disease might go next. Then, once it became clear that a serious emergency was underway, trained personnel should have flooded the affected countries within days. Instead, it took months. Doctors Without Borders deserve a lot of credit for mobilising volunteers faster than any government did. But we shouldn't count on non-profit groups to mount a global response. Even if we signed up lots of experts and volunteers right away, it's not clear how we would deploy them quickly into the affected area or how we would transport patients. Few organisations are capable of moving thousands of people, some of them infected, to different locations on the globe with a week's notice. The Ebola epidemic might have been a lot worse if the United States, Britain and other governments hadn't used military resources to fly people and equipment into and out of affected areas. But we should not assume that the next epidemic will limit itself to countries that welcome Western troops. Data is another crucial problem. Not data are a crucial problem, I note. I've just written to Bill on that one. During the Ebola epidemic, the database that tracks cases has not always been accurate. This is partly because the situation is so chaotic, but also because much of the case reporting has been done on paper and then sent to a central location for data entry. Then there's our failure to invest in effective medical tools like diagnostic tests, drugs and vaccines. On average, it's taken an estimated 1 to 3 days for Ebola test results to come back, an eternity when you need to quarantine people until you know whether they're infected. Compare all this to the preparation that nations put into defence. Armies have systems for recruiting, training and equipping soldiers. NATO has a mobile unit that is ready to deploy quickly. Although the system isn't perfect, NATO members do joint exercises where they work out logistics, like how troops will get food and what language they'll use to communicate. Few, if any, of these approaches exist for an epidemic response. The world doesn't fund any organisation, not even the World Health Organization, to coordinate all the activities needed to stop an epidemic. In short, a battle against a severe epidemic, in that battle, we would be taking a knife to a bazooka fight. We need a global warning and response system for outbreaks. It would start with strengthening poor countries' health systems. For example, when you build a clinic to deliver primary health care, you're also creating part of the infrastructure for fighting epidemics. Trained healthcare workers not only deliver vaccines, they can also monitor disease patterns, serving as part of the early warning systems that will alert the world to potential outbreaks. Some of the personnel who are in Nigeria to fight polio were redeployed to work on Ebola, and that country was able to contain the disease very quickly. We also need to invest in disease surveillance. Finally, we need to invest far more in research on drugs, vaccines, and diagnostic tests. The United Nations should empower and fund a global institution to coordinate these efforts. The UN and the WHO are studying the lessons of this epidemic. Their evaluations will be a good starting point for a conversation about how to strengthen the WHO and what pieces of the system it should lead. I've not seen a rigorous projection for what a system like this would cost, but we know the cost of failing to act. According to the World Bank, a worldwide flu epidemic would reduce global wealth by $3 trillion, not to mention the immeasurable misery caused by the millions of deaths. Preventing such a catastrophe is well worth the world's time and attention. End of quote. By the way, the IHR Emergency Committee on Ebola, which was called together to meet in August, took no time at all to advise the DG to declare that outbreak a public health emergency of international concern. Careful examination of the international health regulations wasn't necessary. Another public health emergency of international concern has been declared in recent times, as you know. Polio, which was so close to elimination just a few years ago, became less close to elimination. It was re-emerging. To listen to presentations from the delegate from Pakistan each year at the World Health Assembly, to listen to that person describe the heroism and all too often the deaths of healthcare workers as they vaccinated infants and young children against polio was awe-inspiring, literally. Polio was once more the subject of discourse at this year's World Health Assembly, and perhaps because I hadn't been following the situation with polio as closely as I should, I was pleasantly surprised at the positive news. The last exportation of the wild polio virus, and now only 2 countries are exporting, and that to each other, was from Pakistan on the 21st of October last year, and from Afghanistan the following day. Experts regard the 2 countries as one epidemiological block. There are 5 countries infected with wild polio virus, but not currently exporting. They're Cameroon, Equatorial Guinea, Nigeria, Somalia, and Iraq. Of all these countries, the most recent case was in Somalia on 11 August last year, almost 10 months ago. Of course, there remains the risk of vaccine-associated paralytic polio, with there being circulating vaccine-derived poliovirus. The endgame plan, and this slide refers to this endgame plan, requires the removal of all polio vaccines, all oral polio vaccines in the long term, beginning with a switch from trivalent to bivalent oral polio vaccine. Eventually, all oral polio vaccines will be withdrawn, replaced by the inactivated polio vaccine, which has already been started to be introduced. Given all the social dislocation in this world, I'm amazed that the world is once again so close to eliminating wild polio virus. Countries at the World Health Assembly last week described their efforts in their most difficult circumstances. Jordan is vaccinating hundreds of thousands of children in their refugee camps. Pakistan has turned their campaign into a military operation. Their description was, once more, riveting. They described a military-style operation to flush out terrorists, the opening up of the north of the country, one-day campaigns, health camps in security-compromised areas, strengthening of cross-border collaboration, and the far better training, recognition and timely payment of their healthcare workers. Religious refusals are no longer the major cause of refusals in Pakistan, and I doubt too many do refuse. But perhaps I'm straying too far from my topic of emerging infectious diseases. I'll return to that, this time to potential pandemics. Of course, we know that the next worldwide epidemic will not come from a disease like Ebola. It will come from an airborne disease, most likely where a victim is contagious before they're asymptomatic. Aileen spent much time considering and preparing for an H5N1 pandemic, which, as we know, is yet to come. What part she would have played in the H1N1 pandemic, we'll never know. She would have been an invaluable contributor to Australia's response in 2009 and to the subsequent review of our national plan for pandemic influenza. The new management plan for pandemic influenza has taken on the lessons from 2009, but remains alive to the understanding that the next pandemic will not be the same as the last. Aileen would also have had avian influenza H7N9 to contemplate. I believe she would have marvelled at the response of China to this threat as she contrasted it to that country's response to SARS. We've seen with H7N9 rapid publicity of the cases, rapid virus sharing, an open invitation for international experts to visit the response, to review the response, to visit the country, and to review their public health measures, which people around the world have been regarded as rapid and effective. This, of course, is an avian influenza, but one that doesn't appear to make the affected birds clinically unwell, but does have a serious impact on human health. The resource we have in Melbourne, the World Health Organization Collaborating Centre for Influenza, is an invaluable national resource as well as being of great regional benefit. Its director, until a few weeks ago, Anne Kelso, has been a most helpful colleague for those of us involved in pandemic and seasonal flu planning in the department. That she is now the Chief Executive Officer of the NHMRC is indeed most welcome to us and an asset to the country. 2 years ago, I was nominated to be a Western Pacific region representative on the WHO Pandemic Influenza Planning Framework Advisory Group. Heard nothing about that until I got a letter saying I was appointed to the advisory group just 2 months ago and to please attend my first meeting a month later. It's appropriate that an Australian is on this group, given the early work by Aileen and by the leading work by Jane Hulton and Simon Cottrell from the Department of Health on virus sharing and benefit sharing to establish this framework. Bringing the framework to fruition has been a long, hard slog, but results are being achieved. The work has been boosted by a recent $1 million donation to the WHO by the Bill and Melinda Gates Foundation to strengthen the PIP Framework Secretariat. The WHO can now better engage with those countries who are the source of the viruses and those companies who make profit from the development of vaccines, diagnostics and antivirals derived from their work on the shared viruses. Now, the notion that countries own the viruses discovered within their borders isn't new. I must admit, I struggle with the thought that any state or country can actually own a virus, but it's just as well that the rest of the world has a different view. It means that through this process, countries that would otherwise not be able to afford pandemic vaccines can now do so. The Nagoya Protocol on access to genetic resources and the fair and equitable sharing of benefits arising from the Convention on Biological Diversity, that's a mouthful, is based on exactly this premise. It has not been a product of health, but more of national governments through their agriculture and environment portfolios. The premise is that states have sovereign rights over genetic and biological material in their territories, and prior consent has to be given and acknowledged before they're shared. The Nagoya Protocol is a 2010 supplementary agreement to the 1992 Convention on Biological Diversity. The protocol itself was adopted on the 29th of October 2010 in Nagoya, Japan, and entered into force on the 12th of October 2014. It's been signed by 193 countries, not the US, ratified by 60 parties, which includes 59 states and the European Union. Australia is yet to ratify the protocol. This protocol does cover the sharing of viruses that affect human health. The PIP framework itself probably does cover the intent and processes envisaged by Nagoya, so there's confidence that that is an acceptable part of this broader Nagoya Protocol. But there is real concern that the sharing of seasonal influenza virus, that will be caught under the umbrella of Nagoya. If so, there is a fear that the willingness of countries to share and receive such viruses will wane because of the requirements for formal agreements between all countries involved every time such sharing occurs. The fear is that less sharing will occur, that which does will be less timely, and time is of the essence when developing effective seasonal influenza vaccines. At the framework meeting, we were provided an update on the state of the art with H5 viruses. Concern about the pandemic potential of these viruses has not waned. The viruses are spreading geographically and diversifying genetically. H5N1 in Egypt is on the rise. due, it is thought, to the proliferation of small family-based poultry farms where the birds are kept at close quarters, closer and within homes in the cold weather. And Egypt, in this most recent winter, suffered through quite a cold one. And to quote Dr. Wenqing Zhang at WHO on the 14th of April, the pandemic threat is hovering ominously. Now, Aileen was instrumental in establishing the Australian Biosecurity Cooperative Research Centre for Emerging Infectious Diseases, of which she was Deputy Director and John Mackenzie the Director. The centre ceased to exist from the middle of 2010 when its funding agreement expired. And I recently read with interest a statement to the Senate from veterinarian Senator Chris Back in 2009, where he put the case for continued funding of the centre. He was particularly concerned about the implications that the loss of the CRC would have had on Hendra virus research, noting the death the previous week in Queensland of his veterinarian colleague Dr. Alistair Rogers from the effects of the Hendra virus. He pointed to the expertise and the research capability found in the CRC, including, of course, the Australian Animal Health Laboratory at Geelong. I've been privileged to make a number of visits to ARL and to be part of its advisory group. It is a remarkable asset for Australia and the world. Senator Back noted that the biosecurity scientific world has moved to a One Health approach in researching highly infectious diseases and cited avian influenza as a high-profile example of a virus passing between wildlife, domestic animals, birds and humans. I can imagine that Aileen would have applauded Senator Back, quietly or loudly, I'm not sure, particularly when he lambasted the CRC reviewers for not comprehending the international importance of the One Health approach. As an aside, I would note that the Australian Biosecurity CRC website is still live, but only until the end of this month, exactly 5 years after the centre closed. Its website remained live for this period to facilitate ongoing access by researchers and end users to the projects and key outcomes of the centre. So if you want one last, or perhaps if you want one first look at this website, you only have a few weeks to do so. Now, you wouldn't be surprised to know that I have a keen interest in One Health. The concept, as expressed by Rudolf Virchow, is that between animal and medicine there is no dividing line, nor should there be, is a succinct description of the aspirations of a One Health approach to disease. We understand that 2/3 of the infectious diseases in humans are due to multi-host pathogens with cross-species lines. We understand the origins of Ebola, of Hendra, of MERS, of H5N1 and H7N9 avian influenza, at least in part. And we know, or at least I believe, that behind every nasty zoonosis is a bat. But I mustn't allow myself to digress down that path in spite of my comment in the abstract you have in your program. What I haven't experienced, however, is a practical day-to-day regular working relationship that gives life to the One Health concept. Until recent years, that is. I've been privileged to be part of such a relationship as we've developed a national strategy for antimicrobial resistance and as we are working to an implementation plan. The national strategy has been signed off by the Minister for Agriculture, the Honourable Barnaby Joyce, and the Minister for Health, the Honourable Susan Lee. The 4-member Antimicrobial Resistance Prevention and Containment Steering Group is composed of the secretaries of the 2 departments, the Chief Veterinary Officer, my colleague Mark Shipp, and myself. Mark and I are co-chairs of the Australian Strategic and Technical Advisory Group on AMR, and the ASTAG is working well as a cohesive unit, utilising each other's undoubted knowledge, expertise and influence to combat AMR. Representatives from animal health, human health and food regulation comprise ASTAG. Scientific groups, clinical groups, researchers, regulators and jurisdictional representatives from both sides bridged the divide to come up with practical initiatives. Aileen would have enjoyed joining in with this group, even if the topic of AMR wasn't her favourite, and I don't know what views she had on that as an issue of importance. The National Strategy has 7 objectives which are compatible with the Global Action Plan endorsed by all member states at the World Health Assembly last week. One thing I did learn, yet again, at the World Health Assembly, is that I lack the patience, the perseverance, or the temperament to make any fist of international diplomacy or international wordsmithing, at least when it comes to writing text such as a World Health Assembly resolution. The resolution regarding the Antimicrobial Resistance Global Action Plan was discussed over 3 days in committee, with at least 70 countries and non-government organisations making representations. They all quickly endorsed the Global Action Plan, but a handful of countries were discomforted by elements of the resolution. Paragraphs were added, deleted, worked, reworked and reworked again over 2 days, enough to make you scream, which fortunately I didn't do, but that was a close call. Thank goodness we have people, and Australia has people, that thrive in this environment. I kept thinking that while the Global Action Plan will be closely read around the world, and it too had been worked on for over a year, so that it really was in very high order when it came to the World Health Assembly, I wondered who would be reading the resolution. Nonetheless, it was required for the Global Action Plan to be endorsed, and endorsed it finally was a week later. The National Strategy's 7 objectives covering education, stewardship, surveillance, infection prevention and control, research, international partnership and governance each have a set of priority areas for action. The working relationships being built up in this One Health approach cannot, I believe, fail to transmit to further the practical working relationships that have already been established here in Australia. Colleagues, Jenny Furman is looking more and more agitated with each passing minute in her role as timekeeper. Goodness knows how Paul Armstrong's coping. For those of you who thought I might have spoken to some extent on the published abstract, I hope I have. Like many of you, I write an abstract only when subject to relentless pressure, and mostly not even then, and well before I have any idea on what I might actually say. For me, it has been an honour to reflect on Aileen Plant and her life's work. It is a privilege to play a small role in furthering the work to which you have devoted your entire careers. Once again, please accept my apologies for not being with you today, but please feel my pain, and if you are so inclined, send supportive texts during your conference dinner. Half your luck, I've got Parliament House food to look forward to. I'm now happy to take questions. No, Jenny, not from you, from the audience. I hear no questions from the audience. Okay, we'll move on. What I want to do is leave you with a slide with some irreverence that I've been constantly told not to display in any conference setting. See if you can spot the irreverence. And it might have something to do with the television screen on the right.